I appreciate the last session finished a little late, and so there'll probably be people walking in, but I'm really pleased to introduce this session on major urological trauma and the major treatment centres. This came about because Chris Moran, who's going to be talking to us in a minute, who's the National Clinical Director for Trauma for the NHS and a Professor of Orthopaedic and Trauma Surgery in Nottingham, contacted me about a year ago and suggested that they'd made massive breakthroughs, as he'll tell you in his presentation, in the improvement of your chances of surviving major trauma. But there were urological problems that weren't always being addressed. And could we get together with one orthopaedic surgeon and one urologist from each of the 24, I think it was at the time, major treatment centres? Well, to be honest, I thought it was a crazy idea. I said, no, let's just get the 5 main movers and shakers together. And Chris said, if you don't get buy-in, it won't work. We've got to get one from each centre. And we pretty nearly achieved that. And I have to say, he was right, I was wrong, because what we've got out of it is a really good document, which I'll be showing you in the second session. So it's a great pleasure to ask Professor Chris Moran to come up to the podium and talk to you on the major trauma networks, the new system in England. Thanks, Chris.
Thank you, and good morning, everybody. My name's Chris Moran, an interloper, an orthopaedic surgeon amongst you. I've got lots of fancy titles, as you can see, but don't be fooled by them. I'm actually a full-time working NHS trauma surgeon. I stopped doing simple TIM hips a long time ago. I still do on-call for trauma and for major trauma. Indeed, I'm on call today, being covered by a colleague, but I'm going to go back to be on call in Nottingham, which is the busiest in the major trauma centres. What we're going to discuss over the next 30 minutes, my aim is to tell you where we were 5 years ago, where we are now, but I'm also going to tell you a story. And this story starts one night in Nottingham, a great boys' night out, the lads go clubbing, and a 23-year-old comes out of the club because he had to stop dancing, because he had a bit to drink. But sadly, on the corner of the road, he went under the wheels of a Tesco lorry, completely under the wheels. When the paramedics arrived, he was in cardiac arrest at the scene, and CPR was being done by a passers-by, his mates, and then the paramedics took over. Now, from 1948 until 2012, the trauma system in England had not changed. Basically, the accident victim was taken by law, by statute, to the nearest A&E, where they received treatment, and then had a secondary transfer for specialist care like neurosurgery, maybe major urology. But the average transfer time from point of wounding to specialist care was 12 hours. From 2012, we have completely changed the system. Only a simple change, really. Now the accident victim has triage at the scene, and then they can be transferred to one of 3 hospitals. The local emergency hospital, which runs a normal A&E service, but doesn't have the facilities for major trauma resuscitation, and these are always bypassed by an ambulance. We have trauma units, there's 120 of these in England. They have the facilities with the trauma team, massive transfusion protocols to provide major trauma resus. They can do a laparotomy, take out the bleeding spleen, and they can triage the patients and then refer on to the major trauma centres those who require specialist definitive care. And then we have 27 designated major trauma centres which have all the facilities for resuscitation and all the facilities for definitive care and rehabilitation of all injuries. So now the triage is absolutely key. If the patient has major trauma, they don't go to a local emergency hospital. If the transfer time is between 60 and 45 minutes, they go to the major trauma centre. Otherwise, they're taken to the nearest trauma unit and then have a secondary transfer. A very, very simple change in the system, which has had profound effects. We now have 11 major trauma networks in the country with 27 major trauma centres. 11 of the major trauma centres deal with children and adults. There are 9 adult-only major trauma centres, 5 children's major trauma centres in the big children's hospitals, And then 2 collaborative major trauma centres, one in Liverpool here and one in Manchester, where there wasn't a single hospital that could provide definitive care for everything. But those cities have made a huge impact by collaborating together. So overall, for England, where we have 9 million children, they're treated in 16 children's major trauma centres, and we have 44 million adults who are now treated in 22 adult major trauma centres. So our guy was in a pretty bad way, but CPR on scene was successful and he regained spontaneous output. And he was triaged to go to the nearest trauma unit or major trauma centre. The paramedics recognised he needed medical care as soon as possible. This is what's happened since 2011 in terms of the movement of patients. And in summary, we have doubled the number of patients in just 4 years who are receiving care in a major trauma centre, either because they're taken directly there or because they have a secondary transfer from a trauma unit. Our lad, his name is Lewis, arrived at 3:15 in the morning. He was received by a trauma team consisting of an anaesthetist, general surgeon, orthopaedic surgeon, and a radiologist. Why does the trauma team make a difference? Well, it makes a difference for a number of reasons. Firstly, we now have a system of pre-alert, so the hospital knows that a major trauma case is coming. The pre-alert allows the team to form and be briefed. It allows task assignment for the team and an equipment checklist. And we heard in the last lecture in here from Tony Giddings how important checklists are. He cited civilian aviation as a really good what path we should follow. I would suggest that for trauma care, military aviation is even better. Military aviation is incredibly safe in terms of flight safety, but clearly pretty risky in terms of what the guys do. And they would never take off without completing at least a minimalist flight checklist. So we have a trauma chain checklist in Nottingham. And you know, Tony was absolutely right. Doctors have complete antibodies against checklists. The way they were introduced didn't work, and so now everybody thinks they're the work of the devil. So what we've done in Nottingham is change it to a trauma team briefing, and suddenly everybody, okay, yeah, we can do that. We can't do a checklist, but we'll do a briefing. It makes a massive difference because standardization gives you resilience. And what that means is that now, wherever you have your accident in England, you'll be received by a trauma team in a trauma unit or a major trauma centre that basically follows the same guidelines, the same checklists, with standardised treatment between the whole country. And that, removing the variation in care, has made a huge difference. So our lad arrived 3:15 in the morning, and he had a consultant team leader managing the team. And we all know, everybody in here is experienced clinicians, how important it is to have a senior surgeon or senior physician leading the team. I'm going to show you this graph a few times over the next 5 or 10 minutes. And this is our national dashboard. This helps me as National Clinical Director have an overview of how our entire national trauma system is performing. And this includes the data from all of the major trauma centres. And what we're going to look at is consultant-led trauma team on arrival for patients who are severely injured. The work starts in 2010 before the trauma centres went live. Here is the point, April 2012, where it went live nationally. And then we're going through by year and quarters up to 2015. And this was our performance before the major trauma centres started. 50 to 60% of patients received by a consultant-led trauma team. And then we saw a significant increase over the next year or two, up to 73% of patients. I'm sad to say we've seen a little bit of a fall-off since that time, so that only 63% of patients are now being received by a trauma team. But hidden within those simple statistics, the simple percentage, is the change in flow of the patients. And we have tripled the number of patients who are now being received by a consultant-led team, because the patients are now flowing to the major trauma centres directly, and the trauma units have reorganised their care to provide consultant-led services. On arrival, Lewis's airway was clear, spine was protected, typical ATLS protocols, respiratory rate a bit high, high pulse, shocked with a blood pressure 106 over 84. He was in coma with a GCS of 6. It was not a cold day in Nottingham, but he had a clear, massive wound across his abdomen, pelvis and thighs, where he'd had an open degloving from where his skin had been spun off by the wheel of the lorry. Because he was in coma, his airway was clearly at risk, and so he was immediately intubated and ventilated. Well, this is the dashboard for performance. You don't really need statistics on a graph like this. This is our improvement in provision of definitive airway throughout the country with the institution of the major trauma system. And it's actually carried on at around 75% ever since. And I'm an orthopaedic surgeon, so I struggle sometimes to understand why it's not 100%, but actually the 25% difference is either patients who clearly have totally non-survivable injuries who are not intubated, they're dying on arrival, or, and the large majority, are drunks who arrive with a low GCS, but after a little bit of gentle encouragement from the staff, wake up. 7 minutes after he arrived, Lewis had a further cardiac arrest. He had CPR for 4 minutes, continued ventilation, and they re-established cardiac output. He had a chest X-ray, didn't show anything particularly major. He had a pelvic injury that showed a whole lot of trouble, completely smashed pelvis. And this is an idea of the sort of wound and degloving that he had from the tyres. Because he clearly had a major problem with his circulation, they started modern treatment for his shock. He had tranexamic acid, a pelvic binder, a fast scan, a massive transfusion protocol was commenced. The change in resuscitation, for those of you who did your ATLS 10, maybe 15 years ago, has been completely a paradigm of care over the last 5 years. We now practice permissive hypotension. That means that we initially restrict fluids. We don't pour fluids in. We keep the blood pressure above 60 to maintain circulation to the brain and the heart, and don't worry about anything else. So we restrict fluids initially now. We don't pour in crystalloid. But that has to be time limited. We know from experience in Afghanistan that basically you can do that for an hour, otherwise you start running into major problems. But a complete paradigm in how we're managing major hemorrhage. And the other big change, I said we don't use crystalloids anymore. I think it's really the devil's fluid. What we need to do is replace blood with blood. And so we've introduced in all the major trauma centres now massive transfusion protocols that aim to provide from the very beginning 1-to-1-to-1 transfusion ratios. One of blood, one of fresh frozen plasma, and one of platelets. And we've just changed the rules. I've done a lot of work with the National Blood Transfusion Service so that we can now have poured fresh frozen plasma available immediately like you have O negative, so that you can give plasma and blood together right from the beginning. Tranexamic acid, I'm sure, is something that you're familiar with in urology. This is a landmark trial, the use of tranexamic acid in major trauma. A randomized trial of 20,000 patients, the CRASH 2 trial, showed a very clear reduction in death from bleeding in patients who had tranexamic acid. Now, tranexamic acid is cheap. It's less than a packet of Smarties to give 1 IV dose of tranexamic acid. This paper was published in 2010, and you can see that it had the usual effect on the medical community: blithe ignorance. Because you know and I know that it takes a long, long time for the results of a randomized controlled trial to translate into general practice. In fact, on average, it's 8 to 10 years. This is what happened with the introduction of major trauma centres, with the standardisation of the care, with the use of checklists. And in fact, we've taken the care even further so that now the tranexamic acid is given on scene by the paramedics. And paramedics are much better than doctors at following orders. It's a bit more military in its approach. So now virtually everybody arriving at Queen's who's shocked has already had their tranexamic acid on scene. Lewis remained shocked, still hypotensive, and the real question was, where is the bleeding? Because he clearly was bleeding somewhere. And so the further paradigm in the care of polytrauma patients is he's sick, he's hypotensive, he's the sickest patient in the hospital, and we took him to CT. And we now regularly take patients to CT who are severely shocked. And the reason for that is based on this paper from The Lancet, but there's other work to collaborate it. This is your chances of dying whether or not you have a CT scan. And basically, you are 6 times more likely to survive major trauma if you have a CT. Because a CT scan identifies exactly where the problem is, which is good, but it also tells you where the problem isn't. A negative laparotomy is a very bad assault on the patient. Sick patients don't like having extra surgery, don't like having their bowels flayed open. So we try and avoid negative laparotomies if at all possible. The number to treat from this study was remarkable, 17. Now we're all surgeons, so numbers to treat of 17 is pretty good. That means for every 17 sick patients you put through a CT scanner, you have 1 additional survivor. Physicians dream of numbers like that. But the other really important message from this study was that the sicker you were, the more you benefited from going to the CT scanner, which is why everywhere's changed their protocols to taking very sick patients into CT to get a definitive diagnosis so you can target the bleeding. And this has been our national performance in terms of time to CT. In terms of an indicator of how the system works, this is probably my favourite, because to get the patient safely to CT scan within 30 minutes with a report means that the system is working well, that the trauma team is functioning well. So this is a really good measure of the trauma system. And as you can see, we've had a definite increase as we've gone live. But again, hidden within the percentages is the huge change in flow of patients and the huge change in the system. So we're now scanning over 3 times more patients within 30 minutes than we were before. Lewis had a hot report by the radiologist, who has become a really key member of the major trauma team. He had a subdural hematoma, and you can see he's got some midline shift, he's got really severely raised intracranial pressure, as well as his skull fractures. His neck and spine were normal, which was good news. His chest wasn't too bad, small left lung contusion, a couple of broken ribs, but nothing too major. Once we get into the abdomen, we started to see some real problems, though. A bit of free fluid, some liver contusion, a clear small bowel injury. And then as we get down into the pelvis, you can see the pelvic fracture. And as we go further down, you can see massive extravasation of urine from his bladder. From CT scan, Lewis went directly to theatre. So he went accident, resus, CT, theatre. Because he'd stabilised, because he'd had blood and not become coagulopathic, a discussion amongst the consultants present took place, and a craniotomy was performed first because he was now hemodynamically stable after resuscitation. Craniotomy performed, believe it or not, by a consultant neurosurgeon. Just look at the time, 4:15. You ever seen that before? He then underwent a laparotomy. He didn't have a bowel rupture, he had a fecal diversion. He had a laparotomy by a consultant general surgeon and a consultant urologist. He actually had a ruptured urethra and a ruptured bladder, a rare but recognised combination. So he had his bladder repaired and a suprapubic catheter inserted. No attempt to do anything to the urethra. He then had his wound debridement by a consultant orthopaedic surgeon and a consultant plastic surgeon. Had a vac applied to it, and then 3 hours after arrival, he was tucked up in bed on intensive care and ventilated. On day 6, he went back thereafter for serial wound debridements. On day 6, he went back, my colleague Darren Forward, who reconstructed his pelvis and did a really remarkable job. It's a fantastic piece of surgery. Day 12, he was extubated. GCS was 15. He had no cognitive impairment. Clearly, he had a bad pelvic injury, and at that time had no sacral plexus function. I was brought up to believe, and in fact, for the first 25 years of my career as a trauma surgeon, that it was impossible really to survive blunt cardiac arrest after trauma. Penetrating trauma, maybe. In my hospital, we've now had 10 patients survive blunt trauma cardiac arrest and leave hospital not just alive, but cognitively intact. A complete paradigm in care. And here's Lewis. He survived to go back out with his mates. Now, it's interesting to reflect, how would Lewis's care have differed just 5 years ago, before the major trauma system evolved and was instigated? So can anybody remember the most important thing that happened in 2011? Rack your brains. You can tell it's a predominantly male audience. It was the wedding of the century in 2011. So Kate and William got married. What would have happened to Lewis? Well, in 2011, on scene, Lewis would have had the same CPR, hopefully got cardiac output. On scene, the paramedics would have given him a litre of saline. In 2016, he was given a small bolus to maintain a cardiac output, gave him tranexamic acid. 2011, he would have been taken to the nearest A&E department. In 2016, he'd have gone to the nearest trauma unit or major trauma centre. In his case, it was one and the same because it was in the city of Nottingham. In 2011, he'd have just arrived at the door, no proper pre-alert for casualty to prepare. In 2016, there was a short time warning to get the trauma team together and brief them. When he arrived in 2011, he'd been met by the casualty registrar, or SHO. There was no trauma team. He'd been given ATLS resuscitation, a couple of litres of saline. In 2016, he was met by a trauma team, intubated early, had a one-to-one transfusion, started immediately, and had consultant-led care. He'd have probably suffered the cardiac arrest in either event. 30 minutes in 2011, they'd have probably got round to asking the surgical reg to come and see him because they thought he was ill. He was having his x-rays. At 40 minutes, they'd have had his x-rays maybe in 2011, maybe started his own negative blood. In 2016, he was in the CT scanner. And by 60 minutes, in the previous system, he'd have been unstable, severely hemodiluted, completely coagulopathic, not a single blood clot forming in his entire body. He'd have been pouring blood everywhere. In 2016, with a one-to-one transfusion, he was cardiovascularly stable so that they could do the craniotomy first, because actually keeping your brain alive is probably more important than anything else. Done by a consultant anaesthetist and a consultant neurosurgeon. Hour and a half after arrival, they'd have probably got round to starting the laparotomy. In 2011, that would have been done by the surgical registrar with the anaesthetic reg. 2016, it was consultant-led care, consultant in general surgery, consultant urologist, consultant in T&O. 2 hours after arrival in 2011, he'd have been bleeding to death. There'd have been pouring blood in at the top, but nothing would have been clotting. I suspect you've all been there at some point in your careers. The blood just pours and you can't stop it. They finally get round to calling the consultant. 2016, he has his wound debridement. That is by a plastic surgeon, so it does take a little bit of time. He's had 8 units of blood only, half the amount of blood we're giving. And I suspect in 2011 he'd have died. What would have followed on? Well, he then went to ITU, had his reconstructive surgery, he had his rehabilitation and went home at day 25. Sadly, this is true. In 2011, we'd have had our monthly M&M meeting. We'd have patted ourselves on the back and said, oh, that was unlucky, completely non-survivable injury, nobody can survive this. We did our best. Day 120, he'd created some work for you, because by this stage he needed a urethral reconstruction. So in conclusion, ladies and gentlemen, have we made a difference with the trauma networks? I'm going to show you one more series of graphs. This is looking at the standardized mortality, the WS in England. It's a complex statistical method, and I'm an orthopedic surgeon, so I don't understand it. We're going to look over the last 25 years, from 1989, when the national trauma audit started, through to 2015. This is the WS, and what the WS basically means is anything positive is extra survivors per 100 patients coming through the door. And remember, we have 25,000 major trauma cases per year. And a negative score is extra deaths per 100 patients. So negative score is bad. And this is where we were back in 1989. And then came the introduction of ATLS. Education, really important. Hugely changed how people thought about managing trauma. We started to work systematically on the individual patient level. And we saw a significant improvement in outcome. Despite hard work by lots of individuals trying to improve the care, not a lot happened over the next 10 years, and the national mortality remained very similar. The next big change to come was actually 2004, the NICE head injury guidelines made a big difference, made neurosurgical intervention much earlier for the severe neurosurgical injuries. But again, following that, we saw a tailing off in improvement. But then, we changed the system. Because we had achieved the maximum that any one of us could achieve as an individual looking after the patient using ATLS. And the problem wasn't the individual doctors. We heard it in the talk before from Tony Giddings. Doctors are good at their jobs, but you can't work as an individual, you have to work as a team. And the patient's life is not saved by the neurosurgeon. It's not saved by the general surgeon taking the spleen out. It is saved by the system. From the immediate treatment on scene, at the point of wounding by the paramedics, right through to definitive care. And the only way we could improve care still further was by changing the system. And that's what we've done. And that equates over since 2008 to around 700 additional survivors per year, which is a paradigm in outcome. So in conclusion, ladies and gentlemen, Lewis is a really good example, a personal example, but a good example of an entire system change, where we have taken the patient to the right place at the right time, but also changed how they're received and treated in those areas. And one thing I've learned is in 2011, I thought I worked in a pretty good trauma centre in Nottingham. I thought we were doing pretty good. And now I look back and I realise we were really crap. We didn't know that we weren't good because we'd never experienced proper teamwork, whole system change in order to get the patient to the right place and receive the right possible care. So I truly believe that standardisation gives us resilience. The knock-on effect of this change is that we are seeing more survivors with severe urological trauma that requires reconstruction, and that's what drove me to contact Mark and see if we could come up with some guidelines to work out how we could manage the small but severely injured group of patients with severe urethral trauma in particular. Because I've come to recognise, and you guys know it already, is that Lewis's life, we've saved it, but unless you sort out his urethral problem, his life will be miserable. And so it's treating the whole patient that's important. Thank you.
Thank you, Chris. Thank you, Chris. We've got time for a couple of questions, if there are any questions from the audience. Chris, I don't know the timescale for Lewis as to whether he was after our meeting a year ago before, but on the assumption he was probably before.
He was before.
Would he have been asked about his sexual function afterwards?
No, absolutely not. It would have been, it's one of the areas that I think that we've hugely underestimated the psychological impact of loss of sexual function in men and women. That our meeting, for me, was a road to Damascus because I learned a huge amount. And so we're now making big efforts in all of the major trauma centres to hugely look prospectively at sexual function and try and improve the care of these patients because the tip of the iceberg is the patients with urethral trauma, urethral rupture, mainly men, but actually behind that tip, there's around 2,000 patients a year with severe pelvic fractures who may also be suffering sexual dysfunction without a ruptured urethra.
Microphone 2.
Thank you very much. This was absolutely an eye-opener, and I can personally, I think, on behalf of all audience, congratulate you and the paradigm shift. But I'm sure you're not satisfied with what you've achieved. I'm sure there's much more to do. And the question is twofold. One is that you mentioned that the actual number of CT scans and the patients have increased or quadrupled or tripled. But are we still lacking resources? That's the first question, to make that numbers better. And number two, what are your directions in the next, say, 2 to 5 years to go further up on that graph which you last showed? Thank you.
Okay, so it's a very good question. So yeah, of course we're lacking resource. It would be nice to have easier and more rapid access to CT scan everywhere, not just in the major trauma centres. There's a huge amount more we could do. In terms of getting more resource, the reality is, and the reality from last Friday as well, is that, and the message I'm getting from DH is there is no money and there is no possibility of any more money. We're actually going to have less money. There's no question of that. So what we've got to do is use our resource more wisely. I think that we can improve a lot. If I had the opportunity with money and I needed to invest, I would actually invest much more in the rehabilitation side than the primary resuscitation side, because I think our resuscitation, reception resuscitation and definitive surgery has improved hugely. And from now on, it's going to be marginal gains. But actually our rehabilitation service and psychosexual function will be part of that, is just lagging a decade to 2 decades behind, because rehabilitation services in NHS have been systematically dismantled by government after government of any colour. And so I think the real area where we need to work on now is not just saving the patient's life, but giving their life back by much better rehabilitation. And we've learned from Afghanistan, from the military, that actually that good rehabilitation can result in remarkable outcomes.
Thanks, Chris. We've got time for one more quick question on microphone 2. Thanks.
Thank you, Mark. Thank you, Chris. Can I ask, please, what Lewis's temperature was when he arrived in intensive care? In our part of the world, we can only dream about the sorts of trauma networks that you talk about, whether we've tried. But a secondary question, are you cognizant of the effects of the hypothermia with prolonged operations, and do you undertake damage control surgery?
Yeah, so absolutely. So we look at 3 things when we're deciding which pathway to take: damage control or definitive care, one of which is coagulation, one of which is obviously the physiology, whether they're hypoxic and lactate raised or high CO2, but the third one is temperature. And the cut-off temperature is 35. Patients with a temperature less than 35, you've just got to get out of there as quickly as possible, save their lives, put them on ITU and rewarm them. And so all of the major trauma centres now put a huge effort into keeping the patient warm so that their blood will clot, and their organs will function properly. So maintenance of temperature is really important. Thank you.
Thanks. So I just want to show you a few slides of the output of the meeting that Chris initiated and we ran in Birmingham last July. You may be able to read the agenda. That was the agenda of the meeting. The striking fact is that we had Chris Chappell and Tony Mundy talking amiably in the same meeting, and we had 21 orthopaedic surgeons and pretty much the same number of urologists getting on well for a full day. And out of it came 5 densely packed pages of notes. And yet Chris told me it had to be written up into a single page. Around that time, we had 4 EAU guidelines came out on trauma, including the very useful short guidelines. Interesting, our own Duncan Somerton was involved in writing 3 of those guidelines. And I'm glad to say that last week we managed to put the output from the meeting on the BAUS website. And there it is. You click on the publications box from last week, and you reach this page, which is a broad explanation of what we went, why we did it, and what they'd shown was a 35% increased chance you'd survive, but a very high chance, around 50-50, that you would have continence problems afterwards and sexual dysfunction. If you go to the website, click on the document, that is our 5 pages condensed onto a single side of 22 points, and it is readable on a plasticized piece of paper. There was a second sheet telling the trauma surgeons how to do a retrograde ureterogram and a cystogram, and at the top was the evidence base for it. And that was 2 nice guidelines, one on complex fractures and one on major trauma, both of which came out in February. And interesting, this week's BMJ is an assessment, a shorter version of these trauma guidelines. And what I like about it is one of the things for research, the first thing for research, is to decide whether contrast CT could actually get rid of cystourethograms because they're getting these CTs so quickly. One more thing, and I've got to thank the andrology section, and particularly Asif Munir and Roland Rees, was we've now written a decent 4-page leaflet, which will be in all the trauma centres, so that the orthopaedic surgeons, when these people have recovered like Lewis, can say, this may not apply to you, but 50% of people like you have problems with sexual function. Please read it through. Let us know, and we will put you in contact with an andrologist. And work still in progress is this spreadsheet, which will eventually go on to the BAUS website, which names the key trauma surgeon, the key urologist in each of the 27 major trauma centres, the andrologist who's linked to it, and where they go for their secondary repairs for their delayed urethroplasties if they've got urethral damage. You can read these as they come up on the screen, rather than me reading them out to you. This is a shortened version, 1 attempt at catheterization by a senior person. If you see blood, you do a cystogram if the catheter goes in. If the catheter won't pass, you do a urethrogram. Any injury, the on-call urologist should be informed early. If the urethral capacitor won't go through a suprapubic, should go in the midline, perhaps in many of the trauma centres by the radiologist who can be trained using ultrasound, and we would recommend a Seldinger technique. You can read these as they go through. Most of this you know very well. Extraperitoneal can be managed conservatively, intraperitoneal not. Any ruptures of the bladder neck need early repair. These are the factors. They're all on the BAUS website. Primary repair is a bad idea by and large. 3-month delayed repair. You see Lewis was repaired at around 4 months, quite correctly. Primary realignment is not to be recommended. The actual binder they put them on often brings the urethra quite close together. All trauma centres now have a link to an andrology service. And as always, as I bang on relentlessly, we have to collect the data. And there is a trauma audit research network called TARN. If you actually want more information on it, there is actually a very good module written by Daniela Andrich and colleagues explaining the management of these patients in BJUI knowledge. And Daniela was also at that meeting. There are 30 screens. It took me around about 20 minutes because this is a slightly bigger module to go through and pass the questions at the end. And like all the modules on BJUI knowledge, there are key points. There were 9 key points at the end. So I want to keep it brief. This, I think, was a really successful initiative, a good way of working together between BAUS and the British Orthopaedic Association. It's on our website. We'll finish the other document. I commend it to you. This is a piece of work that has been very productive. Thank you very much. Now, as I'm here for the rest of the meeting anyway, I would suggest we don't take any questions at the moment, because I want to invite Dav Sharma to come up, because he's going to talk to you about renal injuries, which is the other big urological topic. And they've had a lot of experience of this at George's, so he's very much the man to be talking to us. Dav, up you come. Thanks.
Fantastic, thank you. It's a big honor for me to be here. I never thought I'd ever be in a place like this when I was a trainee or even before that, thanks to the president. I've been lucky in a sense and been honored to work at 3 major trauma centers. I worked at King's when it started out as a major trauma center, and that's a great place to work. And I commend all trainees to go there. You see a lot of stuff at King's. It's quite wild. I worked at Camp Bastion for a short period. That was something else. You'd never see a system as slick as that anywhere in the world, really. The military have such an approach to problem solving and resources that it was out of this world. And then I went to St. George's, which by that time was a major trauma center with a particular interest in pelvic fractures and urethral trauma. Bladder trauma, which we see a lot of. So it's been an interesting journey. Renal trauma, I think, is a real success story, and it's almost a template that we can work off as urologists and as surgeons, as physicians or doctors interested in trauma. There are challenges and there are some directions that I'll talk about. If we look at renal trauma, we're looking at 3 things, really. We're looking at survival. We want the patients to live. We want them to preserve their kidneys as best as possible. And we want them to minimize the comorbidity associated with treatment in particular. So we want to move away from the past where the patient came with an incision from sternum to down to the pelvis, with all the associated problems of laparotomy surgery. And I think it's quite safe to say that we have achieved that, and that's been over the last 20 years, and it's not just by having major trauma centers, it predated that. So if we think of patients with grade 1, 2, 3, and 4 injury, the chances that they would have their kidney and most of the function is probably around 99%. And the chances of having a laparotomy, very, very small. And I think that's a real success story. And we've done very well on that count by working in a multidisciplinary team, by making sure urologists stayed in charge of those patients, by working very close with radiologists, and working very well with emergency department and resuscitation protocols. I think that's really, really important point, because you cannot get patients to intervention urology, intervention radiology without appropriate resuscitation. And the move that was stressed away from saline resuscitation, which is indeed the devil's fluid, to blood product resuscitation has been a huge hit, a huge positive hit for us in organ preservation. So the definition of an unstable patient has changed. You know, we were brought up on a single blood pressure systolic drop below 90 systolic was sufficient for the patient to go almost to theater, whereas now you can give them blood and you can get them into the interventional suite and you can get fantastic outcomes in renal trauma. So a real success story. And at St. George's, we looked at our data recently, and in around 120 patients, there was a 98% non-operative rate. At King's, it was slightly less. King's has a high rate of penetrating trauma for any civilian center, and that's part of the reason why that figure was slightly lower. What about the challenge? Well, it's here, isn't it? Grade 5 renal injury. What do we do? So grade 5 is divided, like most renal injuries, high-grade renal injuries, into parenchymal injuries and vascular injuries. So if you avulse your renal artery, can we save that kidney and can we save that patient? And if you have a smashed up kidney, can we save that kidney and can we decrease the morbidity? So let's look at an example that came in about 6 weeks ago. Bilateral renal injuries. The right side is not impressive, and I wouldn't get particularly excited by an injury like that. I often look at the hematoma, the size of the hematoma, and there's virtually no hematoma. Contusion or a little vascular injury, something like that. The right side, that kidney is not perfusing. So there is a problem. And because it was stated as bilateral renal injuries and one kidney wasn't perfusing, it was felt that there was a need to do something. And what is the main limiting factor that we have here with a vascular injury, a kidney that's not perfusing? And it's usually an intimal flap, a decelerating injury. Well, it's time, isn't it? And we had about 2 hours when this patient came in. I felt the kidney wouldn't survive, but it was felt that we should give it a go. So, an arteriogram, a wire across the injury, and quite amazingly, a stent put in. And that was done within 3 hours of injury. So that's the capability we have to deal with working with our colleagues in resuscitation and in interventional radiology. But this kidney died. So a huge resource was put into it, and it showed what capability we have, the slickness of what trauma teams can do, but the kidney didn't survive. If we go to the literature and we try and interpret it in grade 4 and 5 injuries, and we've just been doing this on the trauma guideline panel, looking, for example, high-grade renal injury, because I would stress that that's where our problems lie, in renal trauma. That's where our challenges lie. There is a move towards non-operative management, but is it safe? Is it the right thing to do? And we screened hundreds of papers on this. And what we come up with is a whole 6 non-randomized studies, 3 single-center studies with a lot of heterogeneous patients, no randomized trials, and a feeling that non-operative management was better overall. However, the groups were not the same in those that had surgery and those that had non-operative treatment. So quite a headache, quite a lot of work, and not much useful information to come out. So what we're left with in our own management and what we think is best is a diagnosis by CT. CT is amazing. It's probably the best thing that's happened to trauma, although there's so much that's gone on. First move towards conservative treatment with resuscitation, which I've stressed, then angioembolization if necessary, and then surgery. And that would mean that the majority of patients would not have major surgery for renal trauma. I love this arterial. Sorry. You'd imagine that renal artery would absolutely hose blood. And that's what we thought. So he had based on the CT scan, he had an arteriogram, but that never bled. The sheath was left in the groin. Patient went to HDU, never bled, and the sheath was removed without need for embolization. And that's what we're seeing more and more of now, that we're more comfortable with renal trauma, that even though there's a contrast blush on CT, the patient usually, oftentimes, doesn't need any intervention but a close eye. Very interesting. So there are opportunities that we need to take a grip of, and certainly the centralization of trauma is one of those opportunities to have major trauma centers that we can collect data at to identify the problem areas that we can do better on. So this is data from King's and St. George's. You can see in 2 trauma centers over 5 years, you get 240 cases. We've got 4 trauma centers in London. We could have over 600 cases over 5 years. If we linked it to Nottingham, Liverpool, Leeds, Leicester, we could have thousands of cases over 5 or 10 years, and we could start analyzing our data and doing much better. And I think that's where a big opportunity lies in the setting of decentralization of trauma. What could we look at? Well, was it appropriate to stent that patient? It probably wasn't, based on the timing of injury. And by dissecting out all vascular injuries in renal trauma, we could get that information. We're not going to get it from randomized controlled trials, and we have to accept that. They're so rare. Timing of surgery, maybe we should be going in and doing laparotomies and removing all the kidney and stopping the bleeding at the early stage. What about complete renal artery embolization? This has happened 2 times in our center in the last couple of years. Is that appropriate? It's actually quite an effective way of controlling bleeding and minimizing comorbidity. The patients do much better than I thought they would, and they don't have a laparotomy scar and the consequences of laparotomy. It's a very interesting area that maybe we could discuss. And what about follow-up imaging, use of antibiotics, thrombophylacsis? So I think renal trauma is a real success story. The modern management is multidisciplinary, and I think urologists are brilliant at being involved in this, and trauma should be no exception. The high-grade injuries are challenging, and the networks allow us to look at better data collection. I was amazed that the managing major trauma would get to the BMJ, but this is this week's BMJ, so it's already been shown. There's lots of people to thank in the whole process of being involved in this, and I've mentioned just a few there. And thank you very much.
Thanks, Dav. Stay at the podium for a minute if you would. Any questions for Dav on renal trauma? Is that Simon Brewster going to microphone number 1?
Thank you. A really excellent session. And I suppose my question is for the jobbing on-call urologist who may not have done a nephrectomy for several years, especially in the light of our subspecialisation. Should he be checking every time he goes on call, he or she, that there is a colleague nearby who can take a kidney out if necessary, or actually is total renal artery embolisation reliable enough now that a nephrectomy would so rarely be necessary?
Yeah, I mean, I think it's a great question, and this is a problem for every single urology department throughout the country with subspecialization, and it's indeed the same for our department. I think that if we work together and work carefully, we can use our interventional radiology colleagues as almost a damage control option in terms of controlling bleeding, so that you can switch the patient from requiring a nephrectomy at the time of presentation to maybe the next day, and even down the line. We have had late nephrectomies as well. And I think that in settings where you haven't got access, certainly and this is with major hemorrhage that needs controlling, and you're in interventional or a hybrid suite or something like that, then I think that the complete artery embolization probably has a role in saving that patient's life, because that's what really matters. I think it's very difficult to rely on just a few colleagues who do partial nephrectomies or major nephrectomies. I think that's a road I think is not one that's sustainable in the longer term.
Go for it, Chris.
That's a very, very good question. I must say that in Nottingham, we've done hardly any nephrectomies, and actually one of the things I'll do after this, the Trauma Audit and Research Network is a fantastic database, 25,000 patients a year going in, and what I will do is go and interrogate that database, find out how many nephrectomies are being done for trauma acutely nationwide. My suspicion is that it's very, very few, and the big paradigm has been the change to interventional radiology. I guess the really difficult ones are those where you've got a renal vein avulsion that comes off with the IVC. And those are a nightmare, whoever or wherever you are, whatever system, because that's
So
tiger territory.
I think what happens in those cases is that those patients go straight to theatre, and the trauma surgeon will do whatever is necessary to control the bleeding. You probably will get a call, but the job will be done, and the kidney will be in the hand of the surgeon by the time you get in, because that's a life-threatening situation. And I don't have a problem with that.
Yeah. And I think one of the things is the major trauma centres now all have to have a 24/7 interventional radiology service, and they are providing that.
Well, thanks everybody. We're finishing 3 minutes early, which is always good. So I'd like you to just put your hands together for the two excellent presentations from Chris Moran and Dad Sharma. Thank you. Really great. Thank you.